Hello everyone, I'm Dr. Priyank Patel, a consultant spine surgeon, and I would like to welcome all of you to the Bombay Orthopedic Society monthly video journal club. At the outset, I would like to thank Bombay Orthopedic Society and Dr. Ashish Fadnis for this brilliant initiative. Today, we'll be talking about treatment modalities for degenerative spondylolisthesis. Should we decompress alone or should we add fusion to the decompression? We often get such patients in our clinic which complain of low back pain, leg pains, and difficulty in walking due to claudication. On their X-rays and MRIs, we see multiple level degenerative changes along with severe compression. The degenerative changes can explain the low back pain. The severe compression can explain why the patient has got claudication. This is when we start thinking about the various treatment options that are available to the patient. So usually we either would want to decompress the patient alone or add fusion to it, which could be instrumented or non-instrumented. Whether to fuse or not. Why is this such a big question? Well, when we decompress alone in such patients, we are always worried if the patient is going to land up with post-op instability, severe back pain, or if we have to reoperate these patients for restenosis or intractable back pain. When we fuse this patient, we are always worried about osteoporosis, what is going to happen to the implants, implant related complications, and of course, a long-term adjacent segment degeneration requiring resurgeries. Several articles are out there supporting both these procedures. There are many which say that decompression alone gives a very good result, and there are few studies which just push towards fusion. So what's the consensus? This was when I came across a study which was published in the Global Spine Journal in 2019. It was a meta-analysis done by Scott et al. The aim of the study was to conduct a meta-analysis to determine the difference in clinical outcomes, complications, reoperation rates for patients undergoing surgical intervention for degenerative spondylolisthesis by stratifying patients into two different groups, decompression alone and decompression with fusion. 531 studies were initially identified after the search, of which 3110 studied were segregated, which were relevant to operative management of degenerative spondylolisthesis. Of this, 56 potential studies containing grade 1 spondylolisthesis cohorts identified after abstract review and read in detail. 24 additional studies were identified through cross-references, making it a potential 80 studies to be reviewed. Of this, 63 studies were excluded. The inclusion criteria were grade 1 spondylolisthesis, cohort of at least 10 or more patients, cohort having degenerative spondylolisthesis managed by either decompression alone or decompression and fusion with a minimum 1-year follow-up. With all these strict inclusion criteria, only 20 studies were included in the final analysis, of which 13 cohorts had decompression plus fusion and 12 cohorts had decompression alone. These were the studies which were finally identified and studied in detail. If you observe carefully, you will notice that almost all these studies are level 3 or level 4 evidence, with couple of level 1 and level 2 evidence. This is because it is usually very difficult to conduct a level 1 type of a study in a surgical group. The parameters that were to compare are the clinical outcomes in terms of VAS score, ODI, JOA, back pain score, and numeric scales for leg and back pain, the complication rate, and the reoperation rate. So here are the results demographic. In the decompression alone group, 12 studies were identified, which included 591 patients, whereas in the fusion group, 13 studies were identified, which had a total of 465 patients. The mean age in the decompression group was 66 years old, whereas in the fusion group was 60 years. And the mean follow-up was 83 months for the decompression group and 46 months for the fusion group. The clinical results were compared using the VAS score for decompression and fusion group both. Both these groups had patients with significant back pain to start with. Post-fusion surgery, patient had significant reduction in their back pain status. However, the interesting thing to notice is that even in the decompression group, the patient had reduction in their back pain. As far as the leg pain is concerned, both had significant leg pain to start with. Both the groups showed significant reduction in their leg pain post-surgery. Of the two groups, The complication rate were higher in the fusion group as compared to the decompression alone group. Complications like infection, worsening radicular symptoms, and durotomies were noted in the decompression group. And complications like permanent nerve damage, pulmonary complications, and subsidence of cage were noticed in the fusion group. This is a forest plot analysis showing the complication rate in the decompression group on the left side and the fusion group on the right side. So forest plot analysis is basically a statistical method to depict the result of a meta-analysis. In a meta-analysis, all the studies that have been included are listed down on the left side, and on the right side, you can see horizontal lines. These horizontal lines depict the 95% confidence interval, and the squares depict the weight of the study. So basically, if the square is smaller, then the number of patients included in the study is less, whereas if the square is larger, then the number of patients included is more. If the line is smaller, then you can rely more on the result, versus if the line is longer, you can rely less on the results. Lower down, you see this diamond shaped structures, which gives you the average of all the studies. So basically here, what it means that almost all the studies have lined up together, telling us that the results are more or less similar in all the studies. Similar thing is seen on the right side in the fusion complication rate graph. The reoperation rates in the decompression alone groups were 8.5%, and the causes were recurrent stenosis, increased listhesis, and disc herniation. In the decompression and fusion group, unfortunately, the causes were not really mentioned and hence cannot be analyzed. This is a forest plot analysis of the reoperation rate of these patients, on the left for the decompression group and the right for the fusion group. Summarizing the result, the mean age was a little higher in the decompression cohort and lower in the fusion cohort. Both groups had similar BMIs, and the male to female ratio was similar in both the groups. However, the complication rate was lesser in the decompression cohort and more in the fusion cohort, versus the reoperation rate was higher in the decompression cohort. Like any other study, this study also has its own limitation. Like for any other meta-analysis, limitation of each study is carried forward. It is limited due to the number of studies because of its strict inclusion criteria. Not all studies included in the study are high-level studies. And analysis for complication is limited, as many studies just documented reoperation and not the cause of reoperation. And the surgical techniques are not uniform in each group. This article definitely deserves our attention as it's published in a well-reputed journal and the authors are of high academic standing. So basically, this study does not support one treatment over the other. However, it highlights some important points. Decompression alone is favored in older patients with predominant leg pain, has lesser complications, however, higher reoperation rates. Decompression with fusion is favored in younger patients with predominant back pain and has more complications but lesser reoperation rates. The important point to note is both groups show significant improvement in both back pain and leg pain. So practically, this article is not really going to help us decide which treatment is better for which kind of patient. However, it does give us a backing for whatever decision we have taken. So let's say if it's an old patient with predominant leg pain with a little bit of back pain, and here we are thinking we don't want to fuse this patient because we don't want to take the chances of implant-related complications, osteoporosis. We have an article that backs this up, and this article also tells us that the patient is going to definitely benefit as far as the leg pain is concerned. However, even the back pain is going to reduce. Similarly, it will also support our decisions in younger patients where we would want to fuse along with decompress this patient. This article also opens up a scope for further studies where you could do a prospective study to find out which particular treatment modality works better in which kind of patients. Thank you very much.